Hello, everybody. This is Lisa Johnson from Everbridge. Thank you so much for joining us here this afternoon. We are going to be talking with Dr. David Levine about his home hospital program, which is bringing acute inpatient care into the home. Our agenda for today is some logistics and introductions, an overview of the home hospital program, the goals for cost reduction and improved patient care, the conditions that were treated during the study, creating a home hospital care team, what remote monitoring equipment and medication was used, how patients and in-home caregivers communicated with each other, and then we'll have a question and answer period. We do ask everyone to, if you're on Twitter regularly, to check us out at EB Healthcare, where we regularly talk about clinical communications. Right now, I'd like to introduce Dr. Levine. He is a practicing general internist and research fellow in the Division of General Internal Medicine and Primary Care at Brigham Health and Harvard Medical School. His research focuses on digital healthcare, care design, and the quality of delivered health care. Among other projects, he leads Brigham's home hospital program to bring acute care to the home for patients who would normally be admitted. Dr. Levine, thank you very much for joining us today.
Thanks very much for having me, Lisa. Good morning, depending on what time zone you're in, or good afternoon, everyone. Thanks for joining us for this webinar. It's really my pleasure and privilege to talk with you all about our program that we've been working on for the last few months at Brigham. Want to also acknowledge an amazing team that's been working on this. Many of those people's names are listed here on this slide. So really, home hospital is all about community-based provision of services usually associated with acute inpatient care. And there's in general three models for home hospital care that have been promulgated. One is the early transfer home. That's where patients are usually in the hospital for probably less than 24 hours, but sometimes up to 2-3 days, and then still need acute care, and they end up getting the rest of their acute care at home as opposed to in the hospital. So that's the early transfer model. The substitutive with the emergency department model is essentially the patient is ill, presents to the ED, and instead of being admitted upstairs, they go back to their home and get substitutive care. And the home hospital unit is deployed in their home. And then the final model is substitutive care without the ED, and everything essentially just pushes right to the home without the patient ever being in the ED. And so for our program, we have mostly focused on substitutive work with the use of the ED, and happy to answer other questions about other models as they come up. So many of the clinicians who are listening right now probably know a lot about the unattended clinical consequences of hospitalization. Among our older patients, about 20% will suffer delirium while they're inpatient. 1 in 3 will lose functional status that they never regain. And then about 5 to 10% actually of our older patients will have a hospital-acquired condition or a fall. So a lot of unintended clinical consequences happen when patients go upstairs. And then there's also, depending on where you practice, poor inpatient access. So often over 100%, often our general medical ward is over 100% capacity. And I know that's how it is here in Boston and in most metropolitan areas, frankly. And so we often see ED wait times of even over 12 hours from the time of presentation to the ED to the time of dismissal upstairs. And then finally, it can be very expensive to take care of patients inpatient. And those costs are certainly not getting any better right now, and we often, particularly for internal medicine, operate in a negative margin nationally for internal medicine admissions. So a lot of things that we'd like to fix about the status quo in hospital care. So want to switch real quick to the first question for you all.
And Dr. Levine, the poll is up now. And
Great.
People can vote. We do very much encourage them to. We have a little trick in our software program in that Dr. Levine can't see the question, but everybody else can.
It's true. I promise you I wrote the question, though.
Yes, you did. So just so everyone can hear it, how often do you think your patients would benefit from a home hospital? And the answers are never, rarely, sometimes, and often. So the answer is 64% said sometimes, 33% said often, and 3% said rarely. So I think we have the right people who are interested in hospital at home.
Very good. Great. So yeah, that's actually probably our feeling as well. So in essence, this is trying to gauge where we're all at. And so there's always going to be a need for the traditional hospital. And the question mark that's often in my mind is where actually can we start to change that dynamic and kind of shrink the need for the very traditional kind of hospitalization for internal medicine patients. And so this is, again, it's all about getting the right care to the right patient at the right time. Certainly not my phrase. But an important phrase. And so this is thinking about that there's a continuum of acuity, right? The ICU being the highest level of acuity we provide for the most part. And then there's step-down services and the general medical floor. And really, home hospital is aiming to take patients who would normally require an acute level of care on the general medical floor and care for them, provide that acute care at home and provide for them at home. And this is really about getting the right amount of care to the right patient, because our hospitals, for the most part, provide the same amount of care to no matter which patient. Every patient in a hospital gets 24 hours of nursing care, no matter whether they need it or not. And so things like that end up making hospitals, or potentially make hospitals, inefficient places. So this is really also about changing the paradigm of I feel unwell, I present to the emergency room, and I end up admitted, and instead, also looking at can we send a patient to a different care context. And we think this is pretty essential to thrive in a globally budgeted system, particularly with shared risk patients where bundled payments are at play as well. And then we also think it's cost saving in the current fee-for-service system. So this is, our work is certainly not the first time that home hospital has been done. We're really building on the shoulders of others that have done some really incredible work. Bruce Leff and his group has been doing home hospital for 10 years at various different sites around the country. Two of those papers are highlighted here. And essentially, they've demonstrated equal safety, equal quality, a 20 to 30% cost reduction, and improved patient experience. None of these papers thus far, and none of these studies or trials have been randomized controlled trials. And so often a critique of these is selection bias, as you might expect. The question mark of, was this patient really going to get admitted? And if they were, what's a true comparison group? And for the clinicians and researchers perhaps on the call, it's hard to say that you can accurately propensity score match, for example, a group of people to the home hospital group. And so this work is actually really begged for a randomized control trial, and that's one of the things we really set out to do here, as well as adding some really some great patient-centered technology. So for our home hospital study and pilot here, we wanted to demonstrate that compared to usual care in the hospital for adults who would normally have been admitted, we primarily wanted to demonstrate a cost reduction of 20%. And then secondarily, we wanted to demonstrate a maintenance of safety and quality and an improvement of quality of life and patient experience. So a lot here to measure, but really rich data. And again, wanted to do all of this in a randomized controlled manner. So we'll go to poll number 2, which I won't be able to see also.
Yes, Dr. Levine, it is up on the screen now, and we would very much appreciate your input so we can help tailor the webinar, but also some follow-ups as well. So for home hospital, which outcome is the most important to you? Cost, safety, quality, or quality of life? And we're getting, and patient experience, which for some reason isn't on my screen, but is being voted on, so that's good.
Good, I heard that one missing. I didn't want to leave that one out.
Yep, no, and people are liking it. So 11% for cost, 25% for safety, 23% for quality, and then 20% for both quality of life and patient experience.
Gotcha. So we're all across the board, which is lovely because guess what? We care about them all also. Very interesting. We must have a lot of clinicians on the line. So in any case, wanted to move forward and just talk about the patients a little bit that we were able to serve. Essentially, we took the bread and butter of internal medicine. So we were able to treat patients with any infectious process that usually boiled down to cellulitis, pneumonia, and complicated UTI. We took patients with exacerbation of heart failure, and we took patients with exacerbations of COPD or asthma as well. So here's how the flow of our study worked. You presented to the emergency department as a patient just as you normally would, and very importantly, we did not interrupt or alter the flow of the emergency room. We really wanted to keep this as a very clean sample of absolutely would-be admitted patients. And so after the decision was made to admit to internal medicine, we would then be able to put a hold on the admission, and the patient would not roll upstairs. And if the patient met our inclusion and exclusion criteria and agreed to enroll, then after that, we would randomize. So again, really minimizing selection bias here. And there was a 50-50 chance. So half the patients still went upstairs anyway. They were very bummed out, but they knew that was a possibility. And the other half were admitted to our team. And I'll describe in just a moment kind of what it looked like for a home hospital module to deploy. I do want to just pause really briefly in that sense to just give you a quick little vignette on a patient that we did have in our home hospital program. This is Dr. William Terry. He was actually featured in the Boston Globe. This is us in his home after his admission. He looks this good always, but he didn't always wear a collared shirt during his admission. And this was a patient that came in with an unclear infectious process. Perhaps he had a possible UTI and even had a possible pneumonia called on his chest x-ray. And we were able to take him home. He randomized to the home arm, got IV antibiotics at home with the home hospital program, and improved quite drastically in the space of a few days. Turns out that he actually had a different infectious process, but we were able to manage that very nicely at home. And he's been very outspoken actually about his experience and is very happy to speak with people about how much the home hospital experience meant to him, and also was very, very helpful to his wife in terms of reducing anxiety and being able to be home with her husband during his home hospital experience. So this was a team that somebody like Dr. Terry would have received. At its core is a registered nurse, a physician goes to the home, and then a home health team that we can ratchet up or down depending on what the patient needs. And really, home hospital is all about patient-tailored need. So that could be a home health aide, that could be home PT or OT, and also a social worker if necessary. Third poll.
Hello, Dr. Levine. It's up now. So the question is, which capabilities would you like to see for home hospital? And the answers are imaging, video, oxygen, telemetry, and food delivery. And you can see the results now. So most popular answer is telemetry at 88%. And then we have video at 73%. Imaging, 65%, oxygen, 63%, and food delivery, 61%.
Very good. Very interesting. Okay, so a little bit of a trick question, because we could do all of these with our home hospital program, but very interesting to see the interest in telemetry and that kind of monitoring. So I wanted to go through a little bit, again, what it looked like for home hospital to deploy. We were able to bring a series of diagnostics to the patient's home, so a limited mobile lab, and we were able to do point of care blood work, including basic metabolic panel and hemoglobin hematocrit at the point of care. We could order echoes as well as portable ultrasounds in the home, and portable x-ray as well were available. We could deliver any acute uncontrolled substance to patients via IV. We could also use all the patient's chronic outpatient meds, and we did that because we wanted to keep patients very much involved in their care as much as they wanted to be involved in their care. So we were able to med rec in the home, which, as many of you probably know, is incredibly powerful to do, and therefore we're able to really organize patients' chronic meds and keep them involved in taking them, and then just supplement the acute meds. And then we had a tackle box that was not filled with fish, but was filled with medications, so we could quickly substitute in or out a new med, just like happens in acute care all the time. We order one thing in the morning and we order a different thing in the afternoon. And so we were able to quickly adjust to those things. And in the case of Dr. Terry, that was certainly a need for him. He needed a different kind of antibiotic at one point, and we were able to quickly swap that in and out for him. In terms of equipment, we use an ambulatory infusion pump that sits on the patient's shoulder or waist, not tethered to a pole, which is so important, we think. And this is able to be patient-controlled as well as clinician-controlled. For our model, our nurses and physicians did all of the work on the pumps here. Believe it or not, we use peripheral IVs. There's often a myth in at least the States that once a patient leaves the hospital, peripheral IVs stop working. In fact, they work really well in the home. So we did not need to have patients with PICCs or midlines or anything like that. We did all of our work with peripheral IVs. And then we were able to provide oxygen via oxygen concentrators so that if a patient with heart failure, for example, or pneumonia did have an oxygen requirement, we could also provide that, and that was not an exclusion. So then in the vein of communication, we had a lot of opportunities to communicate with patients. And so one of the first ways that we did was through encrypted SMS, and that we did through the Everbridge platform that Everbridge provides. We were able to both communicate with clinicians, so clinician to clinician, and in a HIPAA encrypted manner. And then we were also able to communicate with our patients. So every patient, we brought a tablet as part of the program. And so patients could then send us text messages in a secure manner. They could send us photos in a secure manner. If they were worried about anything at all through that platform, which worked quite nicely. Dr. Terry actually is all about writing near books on this platform to the point that I actually asked him to just pick up the phone at one point. But we did have some really great participation with some of our patients in that. We also used a list runner, which is a software that allows us, again, in a HIPAA encrypted manner, to share tasks between our teams. Again, team members. Again, it's a small, sleek team, and we like to keep it that way because it runs very efficiently. But being able to leave each other these virtual tasks was very, very helpful. And then finally, encrypted video. So we were not speaking with Dr. Osler, but we were speaking with the patients often, would call up and show us a problem if they had one, or similarly, the clinician to clinician, so nurse to doctor, could also if the nurse wanted to ping the physician, oh, does this cellulitis look better to you? Things of that sort. We were able to work through some of those things by video, which would then obviate an in-person consultation. And then finally, of course, we use the telephone quite a bit in home hospital. Oftentimes, that's where we saw a lot of our patients were comfortable. So then for monitoring, we used a monitoring patch. It's really interesting to hear that so many of you would want telemetry as a basic core tenet for home hospital. This is actually a very new part of home hospital. The work I cited previously with Bruce Leff and others did not use any of this kind of continuous monitoring. But suffice it to say, we had continuous heart rate, respiratory rate, skin temperature, continuous telemetry. We had sleep detection, falls detection, posture, step counts in near real time for patients. And so that was again, it's a slightly to be proven need, right? Does a cellulitis patient really need telemetry? Maybe they do when they're at home, and maybe it's a way that we're able to cut down on in-person staffing needs. These are some really interesting empiric questions that we're going to be continuing to answer in the future. We certainly noted anecdotally that patients appreciated being continuously monitored, and certainly some of our clinicians appreciated kind of that knowledge that, you know, even though no one's in the home with them right now, we know that in general, most of their vital signs look fine, and we can kind of get some sleep tonight, and they're going to be with us in the morning. So we did take home very sick patients, and so this certainly was a really nice function to have as well. So a lot of our findings are in press right now, so we can't share any of the detailed information yet. We're excited to soon, but suffice it to say that many, if not all, of our specific aims were reached in our pilot population. We were able to demonstrate cost savings. We maintained safety and quality, and then patients had very, very high quality of life and patient experience as well. And so we're really looking forward to actually launching a much larger study in the very near future, where we're going to be able to demonstrate even more of our secondary and exploratory outcomes to a greater degree with a larger sample.
So we did use the Everbridge platform for this pilot study, and there are plans to continue to use it at the Brigham and kind of working with this program going forward. Everbridge in general, most people do know us as the emergency communication tool in hospitals. We're in over 1,000 hospitals in the United States right now. We cover 23% of all hospital beds in the United States. So we are the #1 provider for that, but all the things that make our emergency planners platform so stable also work for our Everbridge platform. And we are HIPAA compliant. We've never had a problem with that, and it can really be a useful tool, as well as with some of the telemetry. If it pings, we can track it. So we connect with well over 100 different devices for tracking purposes. Oops, hit my button. Okay, so we have been doing several studies with our software program with various institutions. We've worked with the Mayo Clinic, and we developed a stroke study where we decreased the door-to-needle time 7.45 minutes. And as you know, time is brain. So we had the opportunity for people to go home instead of staying in hospice, or greatly lessen the severity of their strokes. We have several teleconsult programs going on across the United States in some fairly large institutions. Those will be getting published, we're hoping, sometime in the fall. And then we also have been working on some outpatient telehealth programs as well, not as strenuous as the home hospital programs, but working with ophthalmology, dermatology, OBGYN, family practice. So there's a lot of applications for telemedicine and telehealth programs. And with that, I'm going to go to the first question. So we got several questions about payment structure. So Dr. Levine, can you kind of walk us through, there was a question about CMS in particular, but there were other, like working with private insurers. Can you talk to us about how that works?
Sure. It's a great question. So I think there's probably two ways to think about payment for a program like this. One is if you're in a shared risk or even capitated contract, and the other is if you're in the fee-for-service world. So I'll start with the easy one, which is the shared risk contract. And so where we do see home hospital programs actively, easily integrating with payment systems is where either a health system has shared risk for a patient or has capitated a global payment for the patient. Then it's actually a win-win-win. The health system is able to provide high quality, safe care to the patient for a lower direct cost to themselves. And therefore they're able to keep more of that capitated payment. The patient is able to get care, acute care in their home, and the payer doesn't really see a change because they're going to continue to pay that capitated rate. So it's a big win-win-win in a shared risk setting. Obviously, not everyone is in a shared risk setting in this country for sure. And so where that can, and just to back up one more second, where we do also see home hospital work being done a lot is in Medicare Advantage plans, and there's a similar shared risk or even capitated payment system there. And so a large paper in New Mexico, Cryer and colleagues demonstrated a home hospital system working inside of an MA plan. And so, again, just to harp on the fact that it really is a big win-win-win in those sorts of payment structures. In the fee-for-service world, there's certainly more challenges that are certainly that can be overcome. So this boils down a lot to your clinical context. So if you happen to be working or operating a health system that is over or above capacity, this also is usually an immediate win, because you simply don't have enough beds to put patients, and therefore you're turning down patient transfers, and your ED is full and overloaded and things of that sort. That's often the case in many major metropolitan areas. And so if you are all of a sudden able to add capacity and take care of more of those patients, that's going to be able to create a nice efficiency in your current brick and mortar building, and then also be able to take care of patients in their homes. And that can be done, that can be billed for in a number of ways. You can bill a daily house call to those patients by the MD. And then people are also all across the country becoming creative with maybe this is part of the home health benefit, and we add on to the home health benefit to make it a home hospital. There's also certainly in other parts of the country, people are piecemeal putting together fee-for-service billing, whether it's the infusion plus the home health benefit plus physical therapy, depending on how you pay for those different pieces. So piecemealing together a larger chunk of dollar to take care of the patient at home. And then finally, there are other people who are starting to think about having a modified DRG for home hospital. And I think it's an open question right now whether payers are going to recognize home hospitalization as somewhat of an equivalent to a hospitalization. And you can certainly find examples of that around the country right now.
Great. Thank you so much, Dr. Levine. And then sort of tagging on to that, are there any adjustments that you need to make with malpractice insurance?
Yeah, that's a great question. And honestly, that's one we don't have a fantastic answer to yet. And that's because a lot of our work has been done so far as a study. And so that offers many hurdles, but it also offers many protections. And so we have patients who are essentially agreeing to be in this study. They have a very thorough risk, benefits, and alternatives discussion in the emergency department. And then this has been an IRB approved protocol. And so as such, our malpractice insurers will cover our physicians inside of the study. I actually am not aware of what other facilities who do have home hospital programs do for their malpractice. My thought is that, and at least anecdotally what I've been told, is that there are not changes that need to happen to malpractice that are very large, because essentially, again, we are attempting to provide the standard of care for acute care, and so why that would alter medical malpractice entirely, not clear, and likely doesn't.
Thank you. And then a couple more questions. So how did you provide telemetry services?
Sure. So there's a lot of different offerings out on the market right now for telemetry. There's everything from an old-fashioned telebox system. There are newer patch systems. There are some different wearables. There's even ingestibles coming out, and so lots of different options for that. We went with a patch-based system that we thought was the best. There's probably a dozen companies looking to manufacture or currently manufacturing patches and different wireless systems like that. And so we went through a process of doing diligence and looking through a lot of those different companies before we centered on the one we did.
Great. And then have you ever had to turn down a patient from your study due to their home environment?
Sure, that's a great question. So we do a preliminary screener before we go home, ensuring that things like water and heat are available, and that there's plumbing, and that there's no domestic violence going on. But beyond that, there's an understanding that if we get to a home and it is not therapeutic or conducive to healing, then we will need to turn back around and go back to the hospital. We do work in very, very difficult areas in Boston. We also work in areas that are not at all difficult. And so we have not had to turn anyone around because of the state of their home. We've had one patient, or a few patients actually, decline because they did not want us to come to their home. One patient had a mental disorder and was hoarding, and it was very embarrassed to have people in his home, for example. But I think that's a much more rare occurrence, and it wasn't really a huge problem that we saw.
Thank you. And then I think this one is going to be our last question for today. So how have the patients responded? Can you give us some anecdotal stories about how they liked or didn't like the program?
Yeah, for sure. So there's certainly Dr. Terry that I mentioned. He is certainly a huge advocate of his experience. We measured patient experience very closely, and in general, patient experience was very, very high in the home hospital program, and we're still analyzing a lot of our qualitative surveys from that as well. And we're seeing themes of reduced anxiety while being at home, feelings of greater self-control when at home, and so compared to our control arm. It certainly can be very tough to be in a two-bedded room when your neighbor is up coughing all night or has procedures or is ill, and you're being woken up every 4 hours or every 6 hours for vital signs. It can be difficult to heal in that kind of a scenario, and so I think we saw that reflected in a lot of the qualitative surveys that patients replied to. A lot of patients were just very, very able to be surrounded by their family when they were home, when that family couldn't necessarily travel to the hospital, either because they just physically were not able to, because they themselves were ill or aged. And we also found that it can be very difficult even just navigating and finding a patient's room, especially if there's language barriers. And many of our patients did not speak English as their primary language. And so being able to be in the home was very, very reassuring to patients.
Dr. Levine, thank you so much for joining us today. This is a fascinating topic, and we are looking forward to you expanding your research and continuing to work with you. And thank you to all of our audience members for coming in today and listening.